Good evening, doctors. I'm Dr. Prachi from Shield Healthcare. Apologies for the delay. Dr. Shweta ma'am, who is our speaker today, is having little technical issues with her system. So give us a couple of minutes and we will start within next few minutes. So sorry again and thank you.
Hello.
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 Yes, ma'am, Prachi here from Shield Healthcare. Good evening.
Oh, yeah. Can you see me?
Yes, ma'am, I can see you.
Okay.
Ma'am, can I share your CV? Can I share my slide?
Yes, 1 second.
Sure, ma'am.
I'll just open up my presentation. I don't know why it's gone again. Okay, fine. Yeah.
So I'm sharing my screen, ma'am. I will do the quick introduction and then you can start with your presentation. Is that okay?
Yeah, sure.
Okay. Thank you. Thank you, ma'am. So, good evening, doctors, and thank you very much for joining today's webinar. I'm Dr. Prachi from Shield Healthcare, and our speaker today is Dr. Shweta Tomala. Ma'am doesn't require any introduction actually. Ma'am is MBBS, MS Ops and Gynecology, and currently Medical Director of Sri Devi Fertility Center in Hyderabad. Ma'am completed her post-graduation from NTR UHS Andhra Pradesh and did fellowships in advanced ART training and also in reproductive medicine in USA from various universities, from Cleveland, University of South Alabama, and also in Florida. Ma'am was a speaker, a guest speaker at various national and international forums for fertility-related topics. And with this, may I request Ma'am to continue her presentation on luteal phase support and evidence-based approach. So thank you very much.
Thank you, Dr. Prachi, for that introduction. Yeah. Yes. Can you see my presentation?
Yes, ma'am.
Okay. Yeah. So, very good evening to all of you. So, firstly, I would like to thank Shield and NutriSynapse for organizing this webinar. So, because we are now in the era of individualized controlled ovarian stimulation, every step in the ART procedure becomes very important, right? From the selection of the patient to choosing the right stimulation protocol and also providing adequate luteal phase support, all these things add up to our IVF success. Luteal phase support, which was once considered to be neglected, now has enough evidence and also studies to support and guide our day-to-day practice. So today I will be speaking on the importance of progesterone supplementation in the luteal phase in stimulated cycles. We'll be talking on all the available options for the luteal phase support backed by evidence. And also we'll be having an insight into a newer emerging concept of individualized luteal phase support. In a natural cycle following ovulation, after the extrusion of the ovum, there is luteinization of the granulosa cells and there is initiation of the corpus luteum development and commencement of the luteal phase. The granulosa cells and also the theca cells, they secrete more and more amounts of progesterone up to around 40 milligrams per day and also significant amounts of androgens and also estradiol. It is this progesterone which is secreted by the corpus luteum in the luteal phase brings about the secretory changes in the endometrium and also sets a sort of background for a receptive endometrium where the embryo can get implanted. When we are doing a fresh embryo transfer cycles or a frozen embryo transfer cycles, so we are adding progesterone. That is, we are in the need of adding progesterone in these stimulated cycles because always there is a luteal phase defect in these cycles. Why is there a luteal phase defect in the stimulated cycles? When we look into the stimulated cycle from the perspective of the luteal phase, the length of the luteal phase is noticeably shorter than that of the normal cycle. And also there is an increase, a dramatic increase in the progesterone and also a decline in the progesterone levels in a stimulated cycle. It is this gap which is present between the stimulated cycle and also the natural cycle is known as the luteal phase gap or the luteal phase defect. So what happens in a hyperstimulated cycle to create this luteal phase gap? Because there are supraphysiological E2 levels, because we are initiating more and more amount of follicles, these follicles secrete more and more amount of estradiol. Aspiration of the granulosa cells from the follicles during oocyte retrieval, suppression of pituitary LH in GnRH agonist, and also antagonist cycles resulting in premature luteolysis. So all these things add up to a luteal phase defect in stimulated cycles. Why do we need addition of progesterone in fresh cycles? So in fresh cycles, we either give a HCG trigger or a GnRH agonist trigger. When the HCG trigger is given, because of the half-life of HCG, this HCG stays for 10 to 12 days. And so it sorts of rescues the luteal phase whenever the HCG trigger is given. But the progesterone levels are not so much as in the natural cycle. So these cycles also require the need for progesterone. On the contrary, when GnRH agonist trigger is given, because of the half-life, very short half-life of the GnRH agonist, there is a drastic luteal phase suppression. And also, as you can see here, the progesterone levels are almost nil or zero when GnRH agonist trigger is given. So this sorts of explains us that there is a need for progesterone in the ART cycles whenever we are doing a fresh cycle ART. What happens in frozen embryo transfer cycles? In frozen embryo transfer cycles, also there is a luteal phase defect. This is mainly because there is no corpus luteum in the frozen embryo transfer cycles. Corpus luteum is a beautiful transient ovarian gland which is present in the luteal phase and early pregnancy. It produces significant amounts of progesterone, estrogens, androgens, growth factors, and steroid hormones. And also it produces progesterone with maximal levels of around 40 to 60 nanomoles per liter in the natural cycle. This is an experiment which was done way back in 1973 where they have seen the effects of lutectomy, i.e. that is removal of the corpus luteum and also its and also the pregnancy outcomes. So as you can see here, the red line represents whenever there is lutectomy, that is when the corpus luteum is removed, there is a sharp decline in the progesterone levels and there is abortion. But when you see the blue line, whenever there is a lutectomy, the progesterone levels, they decline, but when exogenous progesterone is added, the pregnancy evolves and it continues. So this can be put in other way, like when lutectomy is done in pregnancies more than 8 weeks of gestation age, the pregnancy continues because there is a luteoplacental shift and the placenta takes over the function after 8 weeks. When lutectomy was done before 7 weeks, there is a miscarriage. Because there is no secretion of progesterone, miscarriages happen. When lutectomy was done in pregnancies less than 7 weeks and exogenous progesterone is added, pregnancy continues. So this explains the importance of progesterone in maintaining the pregnancy. So there is a need to supplement exogenous progesterone to maintain the pregnancy. So the supporting of the luteal phase with exogenous progesterone is intended to increase the chance of pregnancy and also to decrease abortions. So with this in mind, we have so many options available for the luteal phase support. In that we have progesterones, which may be either vaginal, intramuscular, subcutaneous, rectal or sublingual. HCG, then we have dydrogesterone, recombinant luteinizing hormone, and also GnRH agonist bolus. All these options have been used for luteal phase support. So, but are we justified in using progesterone in our ART cycles? Does supplementing progesterone in the luteal phase improve our IVF outcomes? Yes, the Cochrane database has analyzed 8 RCTs where they have compared the live birth rates and also the ongoing pregnancy rates by comparing the progesterone versus placebo or no treatment. What they have found is that the ongoing pregnancy rates and also the live birth rates, they are higher in the progesterone group, and this can be, and we can say that the evidence favors that when exogenous progesterone is supported for luteal phase support, indeed we have good outcomes in our IVF cycles. So the ASHRAE recommendations for 2019, they also strongly recommend progesterone for luteal phase support after IVF and ICSI. So we have so many options available for progesterone. There are so many formulations which are available. It is available as an oral tablet, intramuscular injection, vaginal capsules, vaginal gel, and also subcutaneous injection. So because there are many different formulations, we need to know all the progesterones have different drug profiles. So when coming to the daily doses, vaginal caps, we require multiple doses. Vaginal gel can be given either single or in a double dose. And intramuscular injections that require a single shot, subcutaneous injections also can be given as a single shot. Oral progesterones can be given either BD or TID. Blood concentration is high with intramuscular and subcutaneous progesterones when compared with other formulations. Absorption is good with intramuscular and subcutaneous formulations, and it is variable with the vaginal formulation. Side effects, most commonly all the progesterones are usually accepted by the patient, but only with the intramuscular progesterone we have pain and also this abscess, local abscess formation. Comfort of the patient, they are more comfortable taking subcutaneous and oral progesterones rather than intramuscular or vaginal progesterones. Patient's preference may be more of subcutaneous and oral progesterones rather than intramuscular and vaginal progesterones. So whenever we are talking of the routes of administration of progesterone and which progesterone to choose for our patient, we usually look for efficacy of the drugs and whether they have any side effects and also how they can be utilized for personalized luteal phase support. When we are looking for the efficacy of our progesterone formulations, this is a study which have compared all the progesterone formulations and also the live birth rates. So they have conferred that whether it is IM, oral, rectal, subcutaneous or vaginal, that is any formulation of progesterones, they have similar efficacy. No progesterone is greater than the other. This is a worldwide and web-based survey conducted by Zeev Shoham, where they have looked into the luteal phase support in assisted reproduction. So they have come to a conclusion that in more than 90% of the cycles, a vaginal progesterone is used. In that, 77% only a single agent of vaginal progesterone is used, and in 17%, a combination of IM progesterone and vaginal progesterone have been used. Vaginal progesterone is the most common progesterone which we use in our day-to-day practice. Vaginal progesterone has many advantages because it has a targeted drug delivery. That is, it results in high uterine concentrations associated with the direct transport from the vagina to the uterus. So it has a cervicofundal distribution, which is known as the first uterine pass effect. And also the vaginal progesterone, it reaches a steady state level in the tissue after 4 hours of uterine perfusion. Vaginal progesterone is the most commonly used progesterone, but mainly the disadvantages may be the discharge and also the vaginal irritation if it is used for longer periods. When comparing vaginal with intramuscular progesterone, with intramuscular progesterone, the serum progesterone concentrations are almost 7 times higher than that of vaginal progesterone. But with vaginal progesterone, we have endometrial concentration is almost 8 times higher than that of intramuscular progesterone. And also here, when we see that the endometrial thickness, it improves significantly when vaginal progesterone is given than compared with intramuscular progesterone. So when vaginal and intramuscular progesterone is compared, maybe vaginal progesterone is preferred to intramuscular progesterone because of the disadvantage of the pain for intramuscular injection and also the associated local abscess formation. Subcutaneous progesterone has been introduced way back in 2014, and since then there were many studies which have looked into the ongoing pregnancy rates and also the live birth rates, comparing the subcutaneous progesterone with the available vaginal gel and also the vaginal tablets. So whatever study they have done, they have seen that the subcutaneous progesterone has comparable outcomes, that is, the ongoing pregnancy rates or the live birth rates or the take-home baby rates are almost comparable with that of the vaginal progesterone. And also the advantages of subcutaneous progesterone may be it is easily administered, and also there is no pain at the injection site, and also it can be given in a single shot. So this is a study which was conducted by Venturella in 2018, where they have given a questionnaire to a patients comparing the subcutaneous progesterone and also the vaginal progesterone. So this picture usually depicts the comfort of administration of either a subcutaneous progesterone or a vaginal progesterone. So the patients, most of them have opted that comfort of administration for subcutaneous progesterone is more than that of the vaginal progesterone. And the ease of administration, also the subcutaneous progesterone is easy to administer and there is no pain rather than the vaginal progesterone, because of some patients have noticed that vaginal discharge and irritation is a little bothersome for them. And convenience over the vaginal route is this is what most of the patients have analyzed, or these authors have analyzed, that subcutaneous progesterone is more convenient to take rather than the vaginal route. So we require more and more RCTs and also more studies on subcutaneous progesterone regarding its efficacy on the live birth rates and also the outcomes of IVF to use it in a day-to-day practice. Dydrogesterone is the synthetic progesterone, which we have been using for decades, but for different indications. And from the past 3 or 4 years, there have been studies done for the usage of dydrogesterone in luteal phase support. And there are Lotus 1 and also Lotus 2 studies which have been done in favor of dydrogesterone. Because this is an oral synthetic progesterone, it is easy to administer. It is non-intrusive and well accepted. It is more patient comfort and better compliance, and also it's cost efficient. When we look into the bioavailability of dydrogesterone, it has 3.5 times higher bioavailability than micronized vaginal progesterone, and the dosage of dydrogesterone is also very less when compared to the vaginal capsules what we give. Dydrogesterone we usually give in the dosage of 30 milligrams, whereas micronized vaginal capsules is given in the dosage of 600 milligrams. Maybe because whenever the safety profile of this drug is established, maybe dydrogesterone can be used instead of the other vaginal formulations. This is the Lotus 1 and also the Lotus 2 trials, which were done by Tourné et al. And also Gressinger et al., comparing the micronized vaginal progesterone and also oral dydrogesterone and looking into the live birth rates. So they have demonstrated that oral dydrogesterone has comparable pregnancy rates when compared to micronized vaginal progesterone. So maybe, but the safety profile of this dydrogesterone is not well understood till now. So maybe in the later coming days, we can use dydrogesterone very, very oftenly in our IVF cycles. So ESHRE recommendation is that dydrogesterone is probably recommended for luteal phase support, but it is a conditional recommendation. So coming to the dosage of the progesterone, there are many dosages, many permutations and combinations we use in our day-to-day practice. There are 5 studies which have compared a low dose, that is less than 100 milligrams, with a high dose more than 100 milligrams of progesterone, and they have looked into the live birth and the ongoing pregnancy rates. They have found out that whether we use a low dose of progesterone or whether we use a high dose of progesterone, there is no difference in the live birth or the ongoing pregnancy rates. Does the route of progesterone make any difference? That is, by using intravascular or oral progesterones, or by using the other formulations of progesterones, do we increase our live birth rates? And this is also a meta-analysis conducted by the Cochrane database, where they have compared all the available permutations and combinations of the progesterone formulations, and they have found that the route of progesterone makes no difference in our IVF outcomes. That is, it does not improve our live birth rates or the ongoing pregnancy rates. That is, no single progesterone route or formulation improves our live birth rates. So ESHRE guidelines, according to that, the dosing of natural progesterone, it has evolved empirically, and the usual dosages, what they recommend is 50 milligrams once daily for intramuscular progesterone, 25 milligrams once daily for subcutaneous progesterone, 90 milligrams once daily for vaginal progesterone gel, and 200 milligrams, it is thrice daily for micronized vaginal oil capsules, and 100 milligrams twice or thrice daily for vaginal starch suppositories, and 400 milligrams 2 times daily we can give for a vaginal pessary. So the timing of progesterone initiation is very important for IVF success. There are 6 RCTs which have investigated into the timing of luteal phase support initiation. So they have compared on the day, they have compared the progesterone initiation on the day of oocyte retrieval versus day after oocyte retrieval. So they have found no significant difference in the live birth rates. Second one is on the evening of oocyte retrieval versus on the evening of embryo transfer. There also they found no significant difference in the clinical pregnancy rate. So when they have compared before oocyte retrieval versus after oocyte retrieval, here they have found that there was significantly lower clinical pregnancy rates when luteal phase support was started before oocyte retrieval. And they have compared on day 3 versus day 6 after oocyte retrieval. They have found out that significantly lower clinical pregnancy rates were observed when luteal phase support was started on day 6 rather than day 3. So what we can infer here is that the luteal phase support can be started either from the day of oocyte retrieval to 3 days after the retrieval. And also the ESHRE guidelines also suggest the same. Starting of progesterone for luteal phase support should be in the window between the evening of the day of oocyte retrieval and day 3 post-oocyte retrieval, and not more than that, or not before that, or not after that. When to stop progesterone supplementation is always debatable. So most of the clinicians, they usually stop progesterone on getting the positive pregnancy test. Some continue it till week 6 or 7, some continue it till 12 weeks, and some continue it for more than 12 weeks. So there is no consensus regarding when to stop progesterone supplementation. Here, this is a picture showing the meta-analysis where 6 RCTs were compared where stopping of progesterone for luteal phase support, where they have compared the stopping of progesterone at the time of pregnancy test versus continuing progesterone until week 6 or 7. Does it make any difference? That is, continuing progesterone, does it improve our live birth rates or decrease our miscarriage rates? No. So it's comparable whether you stop the progesterone on getting a positive pregnancy test or you continue it until week 6 or 7. It makes no difference. But the thing is, we need larger samples or larger RCTs to validate this information. And we can see here there was a worldwide survey done in 2014 where they have seen that 15% of the clinicians, they stop progesterone after they get a positive HCG test. 13% stop when they have a positive fetal heart, 44% they continue it till 10 to 12 weeks, and 28% of them they continue for more than 12 weeks. So stoppage of progesterone supplementation depends upon the clinician's practice. So ESHRE recommends progesterone for luteal phase support should be administered at least until the day of the pregnancy test. Use of estradiol along with progesterone in the luteal phase support is always debatable, and this is a Cochrane meta-analysis which has looked into the live birth rates and the ongoing pregnancy rates when they compared progesterone versus progesterone plus estradiol in the luteal phase. And they have seen that whether they add estradiol to progesterone, there is no difference in the live outcomes. That is, the live birth rates or the ongoing pregnancy rates, they are similar when you use progesterone alone or when you combine estradiol with progesterone. But there is one study which is not included in the meta-analysis where they have added estradiol to high doses of progesterone, that is 200 milligrams of vaginal capsules. They have given 3 times per day plus 100 milligrams of intramuscular injections. So when they have added estradiol to this progesterone, they have observed a significant higher clinical pregnancy rates. But this is done only in women undergoing long GnRH agonist and short flexible GnRH antagonist protocol. So this is not with the short GnRH agonist protocol. So this is only one study which has shown that adding estradiol to progesterone during luteal phase supplementation increases our pregnancy rates. ESHRE guidelines, the addition of estradiol to progesterone for luteal phase support is probably not recommended. And also adding of HCG to progesterone in the luteal phase support versus progesterone alone. So this also has been looked in the Cochrane database, and they found out that there were no difference in the live birth rates or the ongoing pregnancy rates when progesterone was supplemented with HCG in the luteal phase support. But when HCG is given in the luteal phase support, one has to keep in mind ovarian hyperstimulation syndrome should always be kept in mind when the luteal phase is supported with HCG. So in patients where HCG trigger is given, progesterone, HCG during the luteal phase support may not be advisable, or it should be looked into with caution because these patients have a tendency to develop ovarian hyperstimulation syndrome. But when a GnRH agonist trigger is given, 1500 IU of HCG is supplemented in the luteal phase, and this has and there are studies which show that supplementation of HCG in the luteal phase when GnRH agonist trigger is given have good success rates. H3 recommendations in HCG triggered ovarian stimulation cycle, HCG as a luteal support in standard dosages of 1500 IUI is not recommended, but this can be done when a GnRH agonist trigger is given. Some of the researchers have also looked into adding a single GnRH agonist bolus supplementation to progesterone in the luteal phase. So they have used either 0.1 milligrams of triptorelin or 1 milligram of leuprolide, and they have added it on day 6 after oocyte pickup. So here we can see that by adding the single GnRH agonist bolus, the live birth rates and also pregnancy or the ongoing pregnancy rates have significantly increased. But the usage of GnRH agonist in the luteal phase support is to be established. That is, the efficacy and also the safety of this GnRH agonist in the luteal phase should be established, and more RCT should be done to validate this data. H3 guidelines, GnRH agonist bolus in addition to progesterone for luteal phase support in HCG triggered cycles, it should be used only in the context of a clinical trial. And also repeated GnRH agonist injections also should be used in the context of a clinical trial. That is, we need more and more RCTs to validate it in a day-to-day practice. Progesterone plus luteinizing hormone for luteal phase support, it was also used only in the context of clinical trial. We do not have enough RCTs to support and validate that by adding LH to progesterone in the luteal phase improves our outcomes. So there is a new concept which has been evolving, which is known as the individualized luteal phase support. As we have the individualized controlled ovarian stimulation, this new concept of individualized luteal phase support has been emerging. Individualized luteal phase support can be done in two ways, either by taking the trigger which is given into account, and secondly by seeing the mean serum progesterone levels which are measured during the luteal phase. So as we can see according to the type of trigger, when HCG trigger is given, either we use vaginal progesterone, intramuscular progesterone, or oral dydrogesterone for the luteal phase support. When an agonist trigger is given, we can supplement 1500 IU of HCG because there is a luteal phase suppression. So HCG in the dose of 1500 IU can be given, which is known as luteal coasting, along with progesterone and estradiol. So these authors have concluded that after the administration of HCG for final oocyte maturation, vaginal progesterone is sufficient to maintain luteal phase support. Luteolysis after GnRH agonist for final maturation is patient-specific and is not always severe. Individualization of luteal phase support after GnRH agonist should be done by using low doses of HCG. So the second concept, which is a new concept which is emerging, is measuring serum progesterone levels in the luteal phase. Does it make any difference if we measure the serum progesterone levels in the luteal phase and we individualize our luteal phase support according to the levels of serum progesterone? Yes, there are some studies which have been done by measuring the serum progesterone levels in the luteal phase. So Brady et al., they have done on the 5th progesterone day, Labata on the 6th progesterone day, and Ansberg they have done on the 11th progesterone day. And from this, here we can infer that when the progesterone levels are more than 35 nanomoles per liter, there is an increase in the live birth rates and also the ongoing pregnancy rates. So in patients who are having, whenever the progesterone levels are done in the mid-luteal phase, if they are having a progesterone levels more than 35 nanomoles per ml, their success rate or their live birth rates and the pregnancy rates increased. So this is the same paper where they have looked into the progesterone levels when they are less than 35 nanomoles per liter and progesterone levels when they are more than 35 nanomoles per liter. So they have concluded that when progesterone levels are less than 35 nanomoles per liter, it decreases the chance of the pregnancy. So this was done in FET cycles, but when the progesterone level is more than 35 nanomoles per ml, definitely our IVF outcomes are increased. This is a newer prospective individualized luteal phase study, which is done in Barcelona. It is yet to be published. And here they have randomized around 600 patients who have underwent PGTA IVF cycles, and they have done a subsequent FET after doing a HRT cycle. So in this, what they have done is they have randomized 600 patients, and they have given them vaginal progesterone 200 milligrams 8th hourly as the luteal phase support. They have done the serum progesterone levels on day 4 of the vaginal tablets, what they have given, day 4 of the progesterone supplementation. They have observed that around 60% of the patients, they have observed that the progesterone levels were more than 10.6 nanograms per ml, and 41% of the cycles they have progesterone values less than 10.6 nanograms per ml. So what they did when the progesterone values were less than 10.6 nanograms per liter is they have added 25 milligrams of subcutaneous progesterone to the vaginal progesterone, what they were giving, like 200 milligrams per 8 hours. And they have observed and they have observed the pregnancy rates and also the ongoing pregnancy rates and the miscarriage rates. So it has been, and they have concluded that when the progesterone levels are more than 10.6 nanograms per ml, the pregnancy rates are higher. But also in patients when the progesterone levels are less than 10.6 nanograms per ml, and when they were supplemented, again added with 25 milligrams of subcutaneous progesterone per day, they also have a higher pregnancy rates and also a lower miscarriage rates. So from this study, we can infer that measuring progesterone levels in the luteal phase support, and if they are low, supplementing them with a little higher doses of progesterone may improve our IVF outcomes. Conclusions: ovarian stimulation alters the luteal phase. In fresh cycles, luteal support appears to improve the live birth rate. Luteal support is mandatory in frozen embryo transfer cycles. Different routes of progesterone administration demonstrated similar clinical efficacy in fresh IVF cycles. So addition of subcutaneous progesterone in FET cycles appears to demonstrate excellent pregnancy rates. Dydrogesterone needs further research on optimal dose and efficiency for FET. Luteal phase support should be individualized according to the patient's specific characteristic needs and desires and the type of treatment performed. Individualized luteal phase support according to the serum progesterone levels, it is indeed a further future step in the management of luteal phase defect in FET cycles. Thank you for listening.
Thank you very much, ma'am. It was a beautiful presentation. You have covered all the points, right from the optimal time, how long it has to be given, the individualization. So actually, these were the questions I had prepared for you, but you have already covered all those points.
Okay.
So thank you very much. I'll just see whether any additional questions are there from the participants, and then I will raise those questions to you. Ma'am, at your center, what is the most commonly used progesterone? That is, which route of progesterone is commonly used?
I commonly combine vaginal with subcutaneous progesterone.
Okay.
Yeah.
And the monitoring is also done with the serum concentration.
Yeah. We usually do in the mid-luteal phase. We measure the progesterone levels, and then according to the progesterone levels, we increase the dose of the progesterone.
All right, ma'am. There is a question, I mean, you have covered this point that how long the support has to be given. This question is from Dr. Salil.
It is how long the luteal phase, I think, right?
How long the luteal phase? Yes.
Usually it is 11 to 17 days for a normal menstrual cycle, but it is shortened in a stimulated cycle.
And the role of L-arginine and N-acetylcysteine in luteal phase support.
Yes, yes. Though there are no studies which have shown that they usually have a beneficial effect, but we do use them in luteal phase support. We supplement L-arginine and also N-acetylcysteine.
Okay. Thank you. Ma'am, I don't find any additional questions in
Okay.
our question bank. So thank you very much. Thank you again for your support. Thank you, ma'am.
Oh, thank you. Thank you for the webinar. Yeah.